Yes, I'd like to welcome all of you. Thanks very much for coming to this April course. I am going to start with talking about a miscellaneous calcifications on a mammogram. Let's go back to the basics very quickly. You know that there is the terminal ductal lobular unit where the milk is produced and where from about 75% of the cancers are originating. And then the second basic building block is the duct and its branches. And these two we call glandular tissue. But they are supported by something we radiologists really like, and that's the adipose tissue. Because the beam goes through and we can see the delicate details of normal anatomy. And then there is unfortunately something, the black sheep in the family, basic building block number 4, the fibrous tissue that unfortunately hides the basic building blocks and also, all too often, hides cancer too. Let's go to the topic. Imagine that you are going to have a case where the only finding is microcalcifications, no tumor mass. And my strong suggestion to you is the following. Please don't look at the shape, the density, the size as every radiologist does it. Yes, it's going to come on the second place, but on the first place, you should really figure out, are these calcifications within the glandular tissue, the terminal ductal lobular units? So the calcifications are going to be clustered, multiple clustered. Or are they localized within ducts? And if they are localized within the ducts, they are going to be elongated or diffusely scattered pearl-like calcifications or the skipping stone-like calcifications. I'm looking at a mammogram which only contains calcifications, and a mammogram looks like this. And you learned it in the school, location, location, location. So you are using your fantasy and doodle as I do, and you say, no, it's not localized within the TDLU. It must be localized within the duct. The other option is that here are the mammograms, and you see cluster calcifications, usually very, very small area, 3 to 5 millimeter. The TDLU originally measures about 1 to 1.5 millimeter. Now it's going to be distended, but not very much, 3 to 5 millimeter. And so then I say they are in the TDLU. Third option is that I say that these calcifications that are hollow, they are in vessels, they are not localized within the glandular tissue, neither the TDLU nor the ducts. They are outside, and then comes a big smiling face. They never represent malignancy. So we could sum up like this. Calcifications outside the fibroglandular tissue, always benign. Calcifications localized within the TDLU, most of them are benign. Just think about fibrocystic change. Think about different types of adenosis, fibroadenoma, and so on. Malignant type calcifications, the minority. And just the opposite is true about the calcifications localized within the ducts. The vast majority are malignant type, and very few, indeed only one, is going to be the benign type. We have already talked a lot about the calcifications localized within the ducts. I'd like to entertain you with this one. This is not only giving you self-confidence, but it's actually fun too. You will see. We call it miscellaneous type calcifications. Let's start with the easiest. Calcifications localized within the skin. This is the sebaceous gland, and here is another one. And they do a very good job because they are producing the sebum. The sebum comes out to the surface. It makes our skin moist, prevent infection, The problem is that we are using different kind of chemicals, and they don't like it, like deodorants. And there will be two kinds of calcifications, calcified sebaceous glands. You see, these are the skin pores. If I magnify the calcifications, are these calcifications within a TDLU? No. Are these long and branching and Y-shaped? That is, are these calcifications within ducts? No. So then I say, smile. This is not going to be malignant type calcification. Because these are the skin pores. And for whatever reason, the sebaceous gland is going to calcify. There will be two different patterns. Nothing more. And you just pick this up and you can put it right in the middle of this one. That is, either the wall of the bag that is calcified, so we got this hollow calcification, or the content calcifies, and that's why we got this tiny little pearl. So you see how efficiently and fast I arrived at the diagnosis. First of all, most importantly, I ruled out the calcifications being localized within the TDLU or in the duct. And after that, I could have just told these are benign type calcification, period. No, you are smart. You think in pathophysiology. These are within the skin as well. Are these within TDLUs? No. Are these within ducts? First of all, we know the distribution of malignant type, ductal type calcifications. They always localize to a single lobe out of the 30 possible. So these are diffusely scattered bilaterally, are not within the ducts, they are not within the TDLUs, they are within the skin. So here we have skin calcifications. Don't even call the patient back. We have skin calcifications belonging to the miscellaneous type. Don't call her back, please, from screening. Now comes an interesting practical advice. By the way, do you know how many skin lesions do we have on our body? About 500. Some of them may be localized on the breast. Some of them may be sticking out, and it's going to be unpleasant and itching and sometimes even bleeding. Women find their way to the pharmacy or a healthcare boutique, and they use creams, ointment, which contains zinc oxide. That's perfectly all right, but not a few days before you go to mammography. Teach your technologist. Dr. Vendrell was very kind to donate this for teaching. Look at this. These are certainly localized in clusters, and they vary in size and shape. Anxiety level goes up. Are these within the TDLUs? No, sir. So the technologists have to kind of educate the female population. Please don't use creams, ointment, which contains zinc oxide. Here we go again. You and me have to call this patient back because she has long calcifications. But it's very strange that this is actually in the axilla. You ask the technologist, would you mind asking the patient to wash her armpit? And suddenly the suspicious calcifications are gone. We can prevent this by educating the women. Don't use talc or skin creams containing zinc before you go to mammogram. Let's change the subject. I see calcifications diffusely scattered just about everywhere from two to top. CC projection. Already these tell me that they could be in the skin. The fantastic benefit of full-field digital mammography is that we can enlarge. We don't need to call her back and magnify. No. Enlarge, and then you answer a question. Are these localized in clusters, multiple clusters, cross-stone-like, bullet-shaped? No. So they are not in the TDLU. Are they localized within ducts? No. They are bilateral, scattered, and each and every one has a hole in it. Take-home message. Hollow calcifications never represent malignancy. because if it is distantly TDLU with the acini containing the large number of cancer cells, and among them the necrosis, and occasionally the calcifications. You see, the calcification is within a hole. Likewise, the carcinoma is growing in the duct, micropapillary solid. That's a central necrosis. And within that central necrosis, there is the malignant type calcification. So it's within the hole. If there is a hole and the calcification surrounds it, that's not a malignant type calcification. So here we have another skin calcification, very extensive. Now it's very amusing that some radiologists are torturing the technologists. Give me a tangential view. Please don't do that. Entirely normal. I would give her a well letter and would say, welcome back, next screening. These are all enlargements, not microfocus magnifications. So we talked about the calcifications localized within the skin. Vessels. Why do you want to talk with very experienced radiologists about vascular calcifications? Well, you are going to be surprised. I have a very interesting series of cases for you. Vascular calcifications. The German pathologist gave his name to this, Mönckeberg sclerosis, arteriosclerosis. In these cases, where it's very extensive, especially when it's in very young women, 30. First question is whether she has diabetes, especially childhood diabetes, whether she has kidney problems. That is, those radiologists who are working at hospitals, there are a large number of patients with kidney transplant, then you are going to see this kind of calcifications because it's the result of tertiary hyperparathyroidism. You just ask the question and you get a good answer. But now comes a topic I'd like to call your attention about. I'm not sure you thought about it. What do you see here? MLO projections, scattered fibrogranular tissue, and Mönckeberg sclerosis. How strange that it's more expressed on the left side than on the right side. Look at the extent and the intensity of Mönckeberg sclerosis. Do you know what happened? This patient had a breast cancer and was irradiated. Dear colleagues, I'd like to call your attention and encourage you about the following. Irradiation intensifies Mönckeberg sclerosis. But unfortunately, this was a cancer on the left side, and that's where her heart is. The heart arteries are going to be damaged by the radiation. And then she's going to die 4 or 5 years later in heart attack, and nobody puts 2 and 2 together. That it's actually probably iatrogenic because we irradiated the left breast. The coronary arteries are just under the chest wall. The coronary might have already been sclerotic, going to be even more sclerotic. We have published a book chapter about the new era, 1 to 14 millimeter invasive carcinomas, stellate lesions, especially if they are unifocal, do not benefit at all from post-op irradiation. Actually, there is a harm. We radiologists who are screening have been exposed to this term in the past 10 years. Screening causes harm. No, that's not true. Overtreatment causes harm. Here we are. Is it convincing for you? Hardly visible here. Very extensive here. So now I touched on 2 different kind of calcifications. This is what I mentioned to you, kidney transplant and so on. So here is a summary so far of the miscellaneous calcifications, vascular calcifications and calcifications in the skin. Smile. Never call her back. Now comes topic number 3. I wonder whether you know about this. She was 36. She just delivered her baby, and she felt a thickening in one of her breasts. where the colleagues found very extensive DAB. But that's not the point right now. Right now, the point is that these kind of obviously vascular calcifications were just about everywhere, of course, bilaterally. Make a note about it. When a young woman just finished nursing the baby, or nursing a baby, or had two babies quite close to each other, and was nursing this and nursing that, and for whatever reason she goes to mammography, and you find this picture, what do you think about? But I'd like to tell you that this is not a Munkeberg sclerosis. Munkeberg sclerosis never disappears. This one does. So it's a transitory phenomenon. It's in the veins. And it's exclusive for women lactating. It's actually cheese in the wall of the vein. I come across this phenomenon about 43 years ago, something like that. She was 28. And for whatever reason, she came to mammography and she was healthy and it was perfectly all right. But then, for whatever reason, 2 years later, she came when she already delivered the second baby and was nursing the second one. And I was shocked when I saw this picture, vascular calcifications. So I started to do the detective job, whether she had diabetes, whether she had kidney problem. And doctor, I just delivered my second baby and I was examined carefully. I don't have a disease. 3 years later, we had a mammogram on her. And then I was nearly shocked. The calcifications keep disappearing. And she's a recurring patient 14 years later. All gone. Look at this. 1980 she had it. 1994 she didn't have it. And of course we have many similar cases. So let me show you more of these type of cases. She's 40. She quite recently finished nursing baby number 8. Can you imagine? She's 40 years old, belongs to a very religious group, and one child is born after the other. That's perfectly all right. And here is her silicone implant. But then you use the push-back technique, and then you see these vascular calcifications extensively in the right and extensively in the left. If you are a well-trained radiologist and you say 8 children, all of them go through breastfeeding, and she has the vascular calcification, don't even call her back, please. I'm going to show you more and more tricky case. Once again, young woman just finished nursing the baby when she unfortunately felt a lump. And that's why she came to mammography. But of course we worked up with all the tools in the toolbox, and we were smiling about these kind of calcifications. But mind you, her palpable lesion was here. So we have right in front of us 2 very different types of calcifications. Vascular, and that's the calcification in the veins. But these are malignant type calcifications. These are still the vascular calcifications, and they are bilateral. But unfortunately, her cancer was palpable here. How difficult case. And fortunately, she pointed this out. Otherwise, I can imagine, would have been oversight. And these are the malignant type calcifications, and these are the calcifications in the vessels. These are the vascular calcifications on the left side. Mastectomy followed. Here are the slices, and then we magnify the slices. And now you can say location of these bullet-shaped calcifications. Calcifications that vary in size, density, and also they are very close to each other. Why? Because the fingers, the acini, are so close to each other. And if there will be malignant type calcifications, they are going to be localized within 5 millimeters. That's exactly the case here. So it's not just the location, not just the shape, but how close they are to each other are going to help me in making the diagnosis. These are 3 clusters of malignant type calcifications. When a woman is younger than 40, and she has a palpable tumor which turns out to be carcinoma, then the basic rule is it's going to be poorly differentiated, as well as it's going to be multifocal. That's exactly what's happening here. Large number of axillary lymph nodes removed, all of them are full of metastasis. Here are the vascular calcifications in the specimen. I hope that this was interesting, talking about vascular calcifications and the different aspects. Traumatic fat necrosis results in very characteristic calcifications, but watch out, there is a trick here as well. Not in this case. Are these within TDLUs? No. Are these within ducts? No, not at all. Can they be outside? Yes. And because there is a radiolucent content. Now, what is radiolucent? Oil, fat. So now I know the pathophysiology which we really love to talk about. Where does the name come from? Oil cyst. It's trauma. So we always have to ask for trauma, and most of all, surgical trauma. Surgeon did a good job. He or she went in, took out the lesion that had to be taken out, and then they also put in a drainage. Whether they want or not, there may be smaller or larger cavities full of blood. And within the blood, there are the enzymes. The enzymes immediately start to work. Here is the neutral fat. They break down the fat to oil, as well as to fatty acids. That oil is responsible for the translucent content. It takes about 1 to 1.5 years when the fatty acids and the calcium within the blood form salts. And that gives the wallpaper. So when you see this extremely high density, even in density, you know that it's quite an old trauma. Some examples. People are aging, old lady patient sitting in front of you has a little medal here, and it warns you, I'm taking blood thinning medicine. So a minor trauma immediately causes hematoma and larger hematoma. If you have this mammogram and you ask about trauma and the patient says, never in my life, never had one, don't ask it again. Because she indeed had the trauma, but she doesn't want to share the story with you. Now come doctors into the picture. Some women want to have larger breasts, or this could have been the result of breast reduction surgery. You see the oil cyst. It's actually scary for the physical examiner because it's very hard, and also the skin may be retracted. These two, hard lump, deformed skin, immediately leads the thoughts to cancer. And then the radiologist says, no, this is post-traumatic fat necrosis. This was the calcification, and inside here is the oil. This one and this one. It's easy when we see that radiolucency here. But what if it's radio-opaque? Then you ask the question, examine the patient, and you're going to find out that this patient had a silicone implant, and that unfortunately produced a capsule. You can imagine this is at least 25-year-old, and it's harder than hard. Certainly not within the TDLUs, certainly not within ducts. After all this, I could ask you a question. What is this? And you would say, not within the ducts, not within the TDLUs. This is outside. And although if you are foolish and don't think, then you say, oh, this is silicone. No, it's not. Please. Silicone is like a golf ball. There is no hole in it. No, this is traumatic fat necrosis. Why? Because some women, especially in the eastern part of the world, these pictures are from Bangkok, want to have larger breasts. And they go to the witch doctor who shoots here, injects. Watch out, this is fat. They heat up some very cheap fat. The patient may die because those who inject fat might cause fat embolism. Don't do that. Relax for a second. What do you think this is? Before you say too much, let me tell you, I got a new camera for myself, and I went out one night and I was shooting at the moon. And the moon had a lot of trauma. That's the surface of the moon. Look at this. And also it has a radial scar too. But here's a trauma. Trauma on the moon, trauma in the female breast. Let's be serious. There are some countries where women really want to have a larger breast. Why she wanted to have a larger breast, not my business. Unfortunately, once again, fat injection. But you as a radiologist can handle it very easily because these are radiolucent, at least partly. But of course, you're not very happy because also this patient expects that you and me are going to find a 1 to 9 millimeter invasive carcinoma here. We are not going to. So far, the post-traumatic fat necrosis type calcification was easy. And now you know that the most reliable calcification representing malignancy, actually very aggressive neoductgenesis, is the so-called casting type calcifications. There isn't one more X-ray sign or imaging biomarker that is as reliable as this, but not even that one is 100%. So what is the 3%? You can imagine that there might be a fibroadenoma, and within that, you see these casting type calcifications. Okay, fibroadenoma can be. But that's not a differential diagnostic problem. Likewise, papilloma can look like this. But then there is the third one that can really mimic diffusely scattered casting type calcifications localized to one lobe in one breast, and then your anxiety level is going up, as it did in our case. 65-year-old, she came with a thickening in the upper portion of her right breast. Smart enough, you're asking about trauma. And she says, yes, I was in a terrible car accident about 3-4 years ago, and my breast was plum blue, but nobody cared about it because my arm was broke. My head was broke, and I had a long way to recuperate. And now I'm here, and I just don't like this thickening in the upper part of my right breast. This is the adenosis pattern, which is a high-risk pattern because the acini are longer. In those acini, there are many more cells, higher risk. Thinking about cancer, especially because of this. Localized to one lobe. They are localized in ducts. They are too close to each other. They are pointing in all different directions. These are malignant type calcifications. On a score scale between 1 and 5, this is super 5. But be careful. There is a basic rule in medicine. You never perform mutilating surgery without microscopic examination. Then you smile. I put my money on this being a carcinoma because even if I ignore the calcifications, this is a palpable architectural distortion. And I learned in school that there are two options. One of them is cancer and the other one is cancer. But keep your head cool and prove your working hypothesis. Because of the architectural distortion, because of the ductal type calcifications, you have to think about malignancy, but you have to prove it. 14-gauge core biopsy, you don't need stereo, you don't need ultrasound guidance. You have a huge palpable thickening. Take a few samples and the pathologist calls you. Job well done. You provided the calcifications, and had it been a malignant casting type calcification, then there would have been an intimate relationship between the bar of calcification as well as the cancer cells. But I warn you, this is not carcinoma. So what is that then? He says it's traumatic fat necrosis. Oh no, there is no histologic sign of cancer. So what are you going to do? And of course, you take out the whole quadrant. And this is the result of segmentectomy, hemosiderin, aging blood, no carcinoma whatsoever. This is traumatic fat necrosis. These are cholesterol crystals. There is no malignancy here. There was trauma, traumatic fat necrosis. A friend of mine, a wonderful, well-trained radiologist running the breast center in California, in Monterey, Dr. Rue, sent me a case. Unilateral, long Y-shaped calcifications, definitely localized within ducts and their branches, malignant type calcifications. It's strange, though, that the calcifications are extremely high density and even in density and smooth contoured. She's well trained, so she just does what we have to do. Prove it. And then the pathologist says, this was the most boring tissue you sent me. Everything is traumatic fat necrosis. No age, nothing. So then Dr. Rue asks my opinion, and I say, would you do a favor for the patient? Just repeat the core biopsy. And she did. And the answer was the same. None of us wanted to believe, so she sent those midget California paraffin blocks, and our pathologist, a brilliant Dr. Todd, told there is no epithelial cell proliferation, nothing. This is traumatic fat necrosis. So, dear colleagues, you see now how I systematically build up your knowledge about miscellaneous calcifications. We already talked about the calcifications of various types within the skin and vascular. We talked about traumatic fat necrosis. Now let's talk a little bit more about ambition in making a relatively small breast larger. There are many ways to do that, and some of them are very foolish, but all of them use silicone. Excuse me? First of all, why do you want to have a bigger breast? Why don't you go to a physician who puts in submuscular silicone implant? You go to a so-called physician or witch doctor who just grabs the breast and injects 1,000 times silicone. And now you come to me and expect that I'm going to find your cancer early. No, I cannot do that. There's no way that there is a radiologist finding a 1 to 14 millimeter stellate lesion, circular lesion here. And of course, you took away the opportunity for a physician to be able to palpate something. Well, because this one is a hard lump and this one is a hard lump and the whole thing is a hard lump. Well, people's education is needed. More of these percutaneous silicone injections. This one too. Now, she came and she was crying. She asked for help. Why are you crying? I have serious nipple discharge. I went to this doctor who injected silicone. From day one, I had this serious nipple discharge. And it just doesn't stop. And my boyfriend doesn't like it. Please help me. I'm sorry, I cannot. Because you see, the witch doctor cannot avoid injecting into the ducts. And these are the terminal ductal lobular units. So this case is a very nice specimen to explain people the basic building blocks. Terminal duct here, major lactiferous ducts. You can have fun. We know it's silicone. She says it's silicone. But you do the ultrasound and you have this snowstorm artifact. Kind of a textbook case. And a similar one. These women come from different countries. You should just enjoy looking at the zillions of tiny terminal ductal lobular units. Some of them are larger, some of them are smaller. So it's an anatomic specimen. Now we go on. She used to have a silicone bag, and she still has it, but it ruptured. You see, traumatic fat necrosis type calcification has a hole inside, but this one doesn't. That's silicone, a ruptured capsule. She reported that her old silicone bag started to behave strange, of course. And if you do ultrasound, then you have this phenomenon we call Linguini sign. And this is silicone. Eventually, Mother Nature is going to localize it, and then it's going to calcify later on. Old silicone bags should not be around. Plastic surgeons recommend that every 10th year you should remove it. And whether the individual person who got the silicone implant, especially if it's in front of the pectoral major muscle, they may react differently. Some develop a capsule around this foreign body very fast. She doesn't like it, and she asked the surgeon to remove it. And now she has clinical problems. She wants to take down one book from the bookshelf, lifts up the arm, and there is a terrible pain. Yes, because this is traumatic fat necrosis, partially calcified, partially oil cyst, which grabs the pectoral major muscle. So then she wants to use the pectoral major muscle, and the scar says, nope. And the pain is obvious. This is what it looks like. Huge oil cyst. This is a silicone granuloma. You can prove it by using core biopsy. The MR can be tricky, but it's not a malignant type MR picture. This one confirms the mammographic diagnosis.